Hello, Dr. Harges.
Hello, Omar. How are you?
So what got you into medicine?
Well, it was largely a matter of chance, I would say. World War II had a lot to do with it. I was graduating from high school. We were in the midst of the war, and there wasn't much choice. It was go into the service. And I didn't relish the thought of being an Army private in the mud or anything, and I thought it'd be a lot cleaner and easier life. Not easier, but a cleaner life in the Navy. At that time, in my senior year of high school, the government had no idea how long the war would last, so they wanted to have a continuing supply of what they considered vital professions or vocations, such as engineers, doctors, dentists, and so forth. So they instituted a Naval Officer Training Program very similar to Annapolis. And I applied and very fortunately was accepted into the Naval Officer Training School. And having gotten into that, you were given several choices, what field you wanted to follow, whether engineering or so forth. And I opted at that time to go into a pre-med course. And I was sent to the University of Richmond, where I was in what was called a V-12 unit at that time. And I spent two full years there in a pre-med course. In the summer of 1945, the training that I was undergoing came to an end, and I was sent to Portsmouth Naval Hospital for the summer and fall of 1945 and served there as a hospital corpsman. And then towards the winding down of the war, they were sending, at this point the war still was going on, and the Navy was still sending men on to graduate school, thinking the war could continue for a long time. So I was sent to the University of Illinois Medical School while I was still in the Navy. And that's how I got into medical school, was due to the good fortune of being in the Navy and doing well in their prescribed training courses, and was sent to medical school. And I had finished the first half year of medical school when we were discharged from the Navy. No, I want to stop for a second. Now, what, I'm trying to think. You were asking how I got into medicine?
Yeah.
Yeah, okay.
What made you decide to become a doctor?
And okay, you want to go on?
Sure. What year did you graduate from medical school?
I graduated in 1949, and this was the first class which had entered medical school at the end of the war. So we were really the first post-war full graduating class. And as I say, I was from the University of Illinois in Chicago. And I, at that time, wanted to see a little more of the world. So I took an internship at Baylor University Hospital down in Dallas, Texas. And by then, the Korean War was in the offing, and I had a good idea that all of us who had received the government training during World War II were going to be called back on active duty as physicians. So with that in mind, I took a Navy-sponsored internship at Baylor University. So my internship was actually served on, quote, active duty with the Navy. Then from there, I went to various fields of well, not training, but service with the Navy. And my first year in the Navy after internship was as a physician in the outpatient department of the Naval Air Station, Corpus Christi, Texas. I found that extremely boring, holding sick call day after day after day. Everyone wanted to get out of duty and coming in and say, hey, Doc, I got a cold, or I got an ache, I got this, or I got that. And I thought, oh, I just couldn't put up with this. So the first thing that came along to get out of there, the Navy was offering, quote, residency in anesthesia at Bethesda Naval Hospital. So I applied for that and was accepted. And I guess it was another backward way into the field of anesthesia. I, at that point, took it as the lesser of two evils, either continuing to do a very boring practice of sick call every day or getting some more training. So I went to Bethesda, and it turned out the quote residency was a residency, but it was a set up as a very short, intensive training course for doctors to go out in the field with the Marine Division in Korea to give anesthesia. So I spent 6 months at combined Bethesda and Georgetown University Hospital. And one of the interesting things was all my fellow trainees at that time periodically were getting sent to Marine training camps at Parris Island. And I never was sent there. And they said, oh, who do you know in Washington that you don't have to go to the Marine training camps? And all the time I said, I don't know anybody. And they said, oh, yeah, you must know somebody because you're the only one in the group that was never sent with field training with the Marines. Well, one of those ironies of the service is, guess who was the first one to go with the Marines? It was me that had never spent a day in training with the Marines. I was sent over to Japan and put into what was called a surgical combat team. And from there I served some time with the surgical combat team in Korea. We were the foremost field hospital doing major surgery with the Marine Division in Korea. So again, it's one of those ironies of fate, I guess you'd say, that having sort of laughable looking back, I was the one that never had the field training in the States with the Marines, and I was the first one to be sent from the Bethesda group in actual combat duty. Then at the end of the war, I was mustered out of the Navy. I still had time to finish a residency, so I finished out my residency in Boston at New England Deaconess Hospital. And served a while on the staff at Deaconess after I finished the residency. I hated the drive to Boston, just Boston traffic. I was living in Natick at the time, and in those days it wasn't like it is now. It was, I guess you'd say, a piece of cake driving into Boston, but I still hated it. And I had a chance to come to Worcester to practice without having to move or anything. And so in the morning, instead of heading east to Boston, I just would head west on the Turnpike or on Route 9 and come out to Worcester to Memorial Hospital. And just spent my whole practicing career at Memorial Hospital. I started out here in Worcester in 1955 and finished, retired in 1990. So I guess that was 35 years I spent it, my whole career just in one hospital. Now, let's see.
What did you choose as your specialty in medicine?
I did anesthesiology. It was a residency I had, and the only specialty I ever did throughout my career.
What made you choose that specialty?
Well, I mentioned before that I went into anesthesia sort of as in the back door. It was a choice to take anesthesia residency and see what that was like, or continue doing very boring sick call duty in the Navy. So it was just a lesser of two evils at that time, as I thought it, and I liked it and stayed with it.
So describe a typical day when you first started practicing here in Worcester in 1955.
Well, when I first came to Worcester, there were only 3 of us in the anesthesia department. So it meant, and we had several nurse anesthetists that were in the department too, and usually we'd start to work at, get in at 7:15 or so in the morning and start surgery around 8 o'clock and work till the day was done. In those days, with only 3 physicians on the staff, it meant being on call every 3rd night and every 3rd weekend for quite a while. And I suppose I put in most days to finish at 4:30, 5 in the afternoon, so probably 10-hour days, except every 3rd day when you're on call, and that was maybe you got some sleep at night, maybe you didn't. It all depended on how busy things were.
So did your typical day change at all over years of practice?
No, not really. It was, start in early and keep working till the workload was done. The number of cases increased dramatically, but as the caseload increased, we kept adding staff too, so it, for each individual, it was probably no more work in latter years than when I first started. It was just as a department, the volume increased a great deal.
Did you ever use the telephone to talk with patients?
Well, I would basically say no, because due to the scope of the practice during anesthesia, it was the contact we had to the patients was face-to-face, seeing them preoperatively in their hospital room or before surgery in the outpatient setting or something. And so I never really used telephone at all. Once in a great while, we would follow up on something if it was a problem, or we thought something may have had some little minor complication from anesthesia. We'd follow up with a phone call and ask how they were doing, but basically telephone had very little to do with my practice.
Could you describe your rounds at the hospital?
Well, the rounds, basically, when I started to do anesthesia, it was a far cry from what it is today. Almost all patients were admitted at least the day before surgery, sometimes 2 days before, and looking back on it, it was rather ludicrous that this occurred. People would come in the day before or 2 days before, and the only pre-op work that was done on them would be sometime a chest x-ray, maybe an electrocardiogram, and a little lab work. And so in those days, 99% of our patients were admitted the day before, so in the late afternoon after they were admitted, we'd go around and make pre-op rounds. As years went on and the cost of medicine increased and so forth, by the time I retired, by a large percentage, I can't give you the exact percent, but maybe 50% or maybe even more of surgical patients were coming in the day of surgery. So it meant we were seeing these patients in the morning after they were admitted and gotten ready for surgery. So the number that we saw in the hospital setting as inpatients greatly decreased over the years, and it's all brought about to the desire to economize on the insurance and hospital stays and so forth, which is a good thing. Because looking back, it was rather silly to have these people come in a day or 2 days before, just lie around the hospital and really have nothing done. So that did change considerably.
Who were your patients? Like, where did they live, and just who were they generally?
Excuse me. Well, the patients basically were Worcester County based. I would say 50–60% in lived in Worcester, and the rest in the surrounding communities. Very little, very few patients came from more than 20 or 30 miles away, I would say.
How many patients did you have in the hospital at any one time?
Well, that really didn't, the question is, doesn't apply to me very much. I never had any patients of my own in the hospital. They were patients of surgeons and so forth, or even medical men that needed some type of anesthesia service.
So what do you think it was like for your family to have a physician in the household?
Well, looking back and what my children and wife had told me in latter years, it was hard in a way, because when I started out when the children were small, I was on call at least every third night, and even when I wasn't on call, I was usually getting home late, never knowing when you're going to get home, and over the years, my kids kept saying, "Oh, Dad, you were never home," and I thought I was home a lot, but in their eyes, looking back, they thought I was away at the hospital an awfully long percent of the time. And it didn't bother me that much, but looking back, I guess I did spend a good part of my life at the hospital.
Did you get any vacations?
Yes. When I started out, I always, I guess I was pretty good to myself on vacations. I would work hard night and day for a number of months on end, but then when vacation came, I would take, when I first started out, 2 weeks a year, then 3, then 4 weeks a year, and eventually 6 weeks a year. So I thought that was very important, that you work very hard when you're working, but then when it came time to relax, why take worthwhile vacation to charge the batteries up again.
So what did you really like about your practice? What made you decide to keep being an anesthesiologist throughout your career?
Well, it's hard to say. Once I started, and I mentioned, got into it sort of the back door, and I found that I liked it. It was challenging, and I thought it was a important part of medicine that was greatly underrated in those days, and I saw a great many changes over the years in anesthesia, and it's anesthesia today is a far, far cry from what it was when I started out. And people today almost laugh when you describe some of the agents and methods you used when I started out. And the modern day anesthesiologists that are finishing training today would probably not even recognize when I'd say phenethine, cyclopropane, ether, open drop ether, and various things like that. It almost seems like medieval practice, but that was the norm. And you know, back in 1949, 1950, we didn't have the agents you do today. We did have pentothal, which was a godsend. And then as the years went along, I think probably one of the most important drugs that I used that came into use in anesthesia was halothane. Made it very easy to induce general anesthesia, and particularly for young children. And, it's an extremely helpful agent. Now it's been superseded, I guess, by newer drugs and instead of pentothal, there's one propofol. I'm not saying that quite right. It's a much better intravenous agent to induce anesthesia. So the people finishing training today and in practice today are using agents that weren't even in use when I retired 12, 13 years ago. So it's in even 12 years' time, it's been a marked change in the field. And it's progressing rapidly. I sort of feel like Rip Van Winkle coming back. If I were to go in the operating room today and see the agents and techniques that are used today, it's rapidly changing, extremely fast, as in all fields of medicine.
So many of the agents that you used back in the 50s are not still used today?
No.
Okay.
In those days, you always had to be aware of the explosive nature of a lot of the agents we used. Cyclopropane ether, under the right circumstances, extremely explosive agents, and you always had to take precautions in the use of that and keep your fingers crossed that nothing would. Unfortunately, I never experienced or saw an explosion with either agent, but it occurred throughout the country periodically, and it's one of the hazards of anesthesia in those days.
Did you always have access to those drugs that you wanted to use?
Yes, no, never was, not like a third world where you were denied access to anything. No, so I was very fortunate. Anything we needed, we were hospital furnished, and we were able to get.
How did changes in drugs and the drug industry affect your practice?
Well, actually, the new drugs that came out and the new, well, you want to say anesthesia machines, different agents, made the practice much easier, and far more pleasant for patients. As time went on, the thought of years ago, you talk to people about their early experiences with anesthesia, and they would always relate back to ether. Remember going under with ether and thinking they were being suffocated and waking and retching and being nauseated and vomiting. And with the improved drugs over the years, that's all but ceased, and it's a very pleasant way to go to sleep now with a little intravenous injection, and it's a godsend for the patients as well as for the anesthesiologist. It's much easier to practice now.
What were the typical illnesses that you saw in the 1950s?
Well, I guess they're the same illnesses that we have today, exception that one of the major illnesses you see today that we didn't have then was AIDS, of course. That's been a life-threatening thing throughout the world, and it was something that was unknown and unthought of in those days. And one of the diseases that when I first started to practice that was always feared, and particularly during the summer months, was poliomyelitis. And today's physicians, I imagine the newer ones, have never seen a case of polio, but back in the 30s, 40s, and 50s, every summer it seemed like there would be somewhat of a polio epidemic. And I remember my first several years in practice in Worcester, we had a number of so-called iron lungs in the hospital, and periodically you would get people in those days in the epidemics and lost their ability to breathe and be put in the iron lungs. So, and there was always the fear that they didn't know exactly why. So whether the polio virus got in through the nose and throat or what, and I always remember in the summer months, the ENT surgeons would stop for a month or so doing tonsillectomies in the late summer and early fall on the premise that perhaps their patients would be exposed more to polio. So they say that's one of the things I remember always every summer, late summer, I'd stop doing TNAs because of the fear that it might lead to polio. And we did see polio in those days. It's something that's very fortunate due to the Sabine vaccine and so forth. It's a disease of the past, I guess you would say today. Another disease that's until the last few years had almost been eradicated was tuberculosis. We used to see more tuberculosis. And I remember as an intern down south seeing a fair number of cases of tuberculosis, and that's almost was wiped out. And now in recent years, in this country, it seems to be increasing due to the influx of immigrants from the Vietnam and the Far East who have a much higher incidence of polio, of tuberculosis. So it seems from what I read that there's been an upshoot in the number of cases of that. But that was a disease that until recent years was almost wiped out due to the newer drugs and methods of treatment. So there's two diseases that early on I used to see more of and don't see today. Another drug I can think of was rheumatic fever in children due to the streptococcal infections, I guess it was, that caused it. And I remember days of medical school and so forth. In Chicago, there was a hospital that most of the patients were those children with the aftermath, cardiac aftermath of scarlet fever with rheumatic heart disease and so forth. And that's pretty well gone by the wayside now. And that hospital has long since gone out of operation. And I never saw them in my own practice, but the childhood diseases, whooping cough and measles, mumps, all that, with the newer vaccines that are available, those diseases are almost a thing of the past. When I was growing up, everyone seemed to get the measles and whooping cough and mumps and so forth. It was common. Those days, the Board of Health in the town I grew up in, I imagine every other town in the country would come and post, if you had measles or something, they would quarantine, put a quarantine sign on your front door, measles or something, and no one's supposed to come in. And it seems almost like medieval times when you think about that now. I've never heard of quarantine years and years and years. So that's changed medicine a lot. The preventive medicine aspect, which is, I think, where a lot more of the money should go on the prevention of disease. Same way with the smoking and so forth. If you can prevent most of these diseases by proper preventive care ahead of time. I think that's where the money should go, rather than treating somebody terminally with a disease that you know you can't cure. And to me, that's one of the great drawbacks of medicine today, is seeing the huge amounts of money being spent on terminally ill patients when there's no hope for them. And I'm very philosophical on that, and I think when it's time to go, don't prolong it with the intravenous's and the endotracheal tubes and all these things that only prolong a miserable life for another week or two. And I think morally and ethically, that's an entirely bad aspect of medicine today, and I certainly wouldn't want to be kept going just to be a heart-lung preparation. And I have very strong feelings on that. We're not putting the money where it should be in the care of infants and children, and somebody that's got a future ahead of them. That's where the big money should go, and rather than somebody that's lived their life in their 80s or 90s. And I get very strong feelings on that.
So what would you classify as, which disease would you classify as the greatest challenge for doctors to treat when you were practicing in the 50s and 60s?
Oh, gosh. I just can't give you any definite answer on that.
Okay. What did you see as one of the most important breakthroughs in disease treatment during your career? You already mentioned some in disease prevention, but in treatment?
Well, antibiotics. From not necessarily when I first started practice, but from the time I was a child, I remember growing up, 3 or 4 acquaintances of mine over the years died of ruptured appendices. And this was before the days of antibiotics. And I remember a neighbor girl lived 2 doors from me. She missed a whole year of school. She had a ruptured appendix and survived. And I remember 3 others, kids in town I knew, not real good friends, but I knew who they were and so forth, and died of ruptured appendices in those days. And today that's almost an unheard of thing due to the advent of antibiotics, which has made a tremendous difference in the treatment of disease, not only the ruptured appendices, but any of the infectious diseases. It's not the threat that it used to be. Pneumonia and so forth. It used to be a common cause of death in adults when I was a child, and made a huge difference. That's probably one of the biggest advances I can think of.
Could you briefly describe attitudes towards smoking and cancer throughout your career?
Well, I never smoked myself, and I always thought it was a foul habit. I always remember my father used to smoke cigars and chew tobacco, and I thought that was disgusting to smell cigar butt around the house in the ashtray, or he'd be outside working and chewing tobacco and spitting all the time, and I just shuddered when I think back, and people still do it today. I just think it's a terrible habit, and it's very leads to so many complications: heart disease, vascular disease, respiratory disease, things that's costing the economy billions of dollars a year, trying to cure or palliate the effects of a poor lifestyle. That's the way I look at it. And I do notice that tremendous change in recent years, even among physicians. At one time, there'd be great numbers of the doctors in the lounge smoking, and today, around doctors' lounges, it seemed like to me very, very few smoke. You go out today in a restaurant. One time, I almost hated going out to eat. Everybody around be smoking. Today, why, it's a rare individual in most restaurants that you see smoking. And it's, I think it's been a great advancement for the lifestyle. It's still I I think the big problem is the young teenagers, particularly the females, seem to be, to me, the ones that are smoking the most. That's my observation, and I just wish you could stop it in the teenage group. That's where the habits start and hard to break.
What technology do doctors seem to take for granted now in your field of anesthesiology or generally in medicine that you didn't have during your career?
Well, probably in anesthesia, one of the things are the placement of lines to measure the cardiac pressures and so forth, which had come into vogue before I retired, but when I started out, these things were unknown, and the technique of adequate fluid replacement and measurement of adequate fluid replacement in patients and so forth by cardiac catheterization and the pressure monitors that they have today. It's been a big advancement.
What technology is still being used that you used frequently in your career?
Well, I might mention in the question before, we also, in anesthesia, particularly end-tidal CO2 monitors, oximeters to measure the concentration of oxygen in the blood. These are all things that over the years evolved while I was in practice. I didn't have when I first started out. And it seems almost primitive when you think that when I first started in anesthesia, about the only monitoring devices we had were the blood pressure cuff and the stethoscope, and the routine monitoring of electrocardiograms during surgery. During anesthesia didn't come into vogue until long after I had been practicing in anesthesia. And it seems so taken for granted today, but as I think back, we didn't even have a routine electrocardiogram monitoring of patients in surgery until, well on into the 60s and 70s, I guess it was. So that's been a big change.
Name one important invention that you've seen throughout the course of your practice.
Well, I think not so much in my own practice, but what I've seen in medicine are the advent of the CAT scan and the MRIs, which are routinely used today that weren't in vogue in those days. I can think in surgery, use of the laparoscope is something that is in recent years, and seems like it can do almost any operation that you can think of with the laparoscope today, and avoids the long, 8-10-inch long scars into the abdomen, and it's been a great advancement. Microsurgery, the use of the operating microscope, something that over the years I saw evolve, and for very delicate work. And when you look at under the microscope, the beautiful little suturing you can do with that in relation to the naked eye, there's just no comparison. It's been a great advance. And little things like that have crept up in the practice of medicine so slowly that I only realize what's happened when I look back and think, well, gee, we didn't have that years ago. And there's a lot of other things, too, that I probably can't think of in the spur of the moment, but these things really stand out in my own mind. Staples to close skin, just rather, it's taken for granted today, but there used to be every incision be closed meticulously by hand. Now the staple gun, in a few seconds you can do it. 20 minutes of suturing years ago. Little things like that the modern person in medicine starting out just probably thinks it's been around forever. It's only been a few years.
Do you remember when some of those advancements came into medicine exactly? When exactly you saw them?
Oh, I can't tell you the year, but they've crept in so gradually. You'd hear that maybe at Mass General they were using a CAT scan, and Then there'd be a few other hospitals around the country. Then pretty soon it might be one hospital in Worcester would break the ice and bring it to Worcester and so forth. And it just happens so gradually that you don't realize it's all of a sudden around you. Another thing I can mention or advancement was the kidney stones. Used to be anybody that got kidney stones was operated on. After numerous times, you get scarring of the ureter and so forth. Now today they have the I'm trying to think of the correct name. They immerse the patient in the bath, or even some type of a belt they put around over the kidney area with sort of an ultrasound crushing of the kidney stones, and they flush the stone out, and it saves all the kidney surgery that used to go on. It's been a big advancement for people with recurring kidney stones. You can just get rid of the stone by the I guess the ultrasonic vibrations, and they flush it out and prevent surgery. Great advancement.
Is there anything that you would like to see invented today in medicine?
Oh, you know, a lot of, trying to think of it, I can think of any inventions we need that we don't have. It seems like they have artificial joints for almost every joint in the body today. You have dental implants if you lose your teeth. At times it seemed like not much more to be invented. Cochlear implants for the deaf. And I've often thought that, it sounds sort of like a Buck Rogers thought, but I've often thought that there must be some way, some year, that somebody can invent a device to aid the blind, almost like a, if you get the, like a night vision scope, something like that, that can, that's not exactly what I mean, but some type of a headset that maybe a person could put on their head, relay, the machinery relay the vision that it's seeing to electrical stimulation of the brain to impose somehow a picture. So, and it seems far-fetched, but I think someday you'll see that. It's some type of invention to enable a blind person to see due to stimulation of the visual area of the brain. I think it could be worked out.
I'm sure people 20 years from now won't see that as too
Yeah,
far-fetched.
that, and also for the paraplegics. Somehow, someday, I hope that they'd be able to find a way to enable the spinal cord to regenerate, or major nerves to regenerate better and functionally, which would be a tremendous invention or advancement. I think those two areas would be two great areas for future people to invent.
How did patients without money receive health care in the 50s?
Well, largely due to the largesse of the doctors, and that's one of the changes I see. In those days, when I started out, you didn't expect to get paid by everybody. I think most people I was in training with early on expected to do a certain amount of pro bono work in medicine, which no one today seems to be instilled with that thought. They agreed to, like the corporate executives in America today, I think has gotten into medicine to a certain degree, that a lot of doctors, all they think about is the income first, and if the person doesn't have money, they don't want to treat the patient. And hospitals have become very impersonal on this. At one time, persons without money, to my knowledge, were never kept away from the hospital I worked in. There was always some kind of a charitable foundation or so-and-so trust to take care of people if they were hospitalized and didn't have any funds. And that whole philosophy seems to have disappeared today, where hospitals did they had funds for the indigent people. And I can never recall anybody that really needed surgery that didn't get it. And I think the expectation of the doctors has changed. In those days, I know I started out, the particularly the elderly people. A lot of them didn't have funds, and you just figure, well, it's just part of practicing medicine. You make your living from those that can afford it, and the others, why, you're glad to extend care to them. And I think the hospitals did this in those days. It's a different ball game today. Everything's the bottom line. It's too bad.
How do you think Worcester compared to other places in terms of providing care to the underserved back then and over the years as you practice?
Well, I can only speak, in the Worcester area. I don't know how other communities did, but in hospitals in Worcester, you had the Worcester City Hospital for years, which the people without funds basically were served mainly by Worcester City Hospital, and I think St. Vincent's and Memorial and the other smaller hospitals in town all did their share of charity work, and they somehow managed to provide the care. And
what were some fears and concerns about socialized medicine in the 50s and 60s?
Well, I think the thought of socialized medicine coming in was more of a threat than it turned out in reality. I think people were always worried about socialized medicine coming in and dictating exactly how a person or a physician would practice, and would put too many limitations on them and so forth. And to some degree that's true, but I think the threat of that's greatly overemphasized. And I think it was the thought that everybody would lose the freedom to practice as they felt best. And to some extent, that's the big battle that's going on today, with people worried about HMOs telling them how to practice, and telling them more how to practice via the economics of it rather than the medical need for it. And it's a big debate, and I don't know the real answer to it. It's one of the problems we're facing in medicine today, the HMO versus government regulations.
As managed care came into medicine with Medicare and Medicaid in the 60s, how have you seen patients and physicians and generally people's access to care all be affected by those things?
Well, I think with managed care, the big thing that's come in is, again, it's the bottom line. What's it going to cost? And not so much as does the patient need it or not, but it's, well, medicine's sort of being practiced by people who aren't really in the medical field. In other words, you must get clearance today from a lot of your HMOs whether you can be admitted to the hospital or not, and it's a clerk, some insurance office somewhere that says yes or no, rather than somebody with a knowledge of whether the person really needs to be admitted and when they can be admitted, or whether they'll, if they receive certain types of treatment, whether the physician at the hospital will be reimbursed by it. And it's gotten to be it's taken away sometimes the medical necessity of treating, and it's become sort of the economic treatment of the patient, and which is bad. And I think that's the big fear that medicine has today, that they're being handcuffed and not being allowed to use their own judgment as much as they would like. And it's probably only going to get worse.
So you've seen people's access to care generally just negatively affected by...
Yeah, I think so. It's yeah, it's got to be the insurance company, the provider, whatever health insurance coverage a person has, is trying to get in the driver's seat and dictate what care the patient can receive and how many treatments they can receive and so forth. And it's one of the big debates going on today.
What are some positive and negative aspects of HMOs?
Well, positive things of HMOs, I think more and more of them are stressing the wellness part of living. proper the coaching or classes on nutrition, on exercise, the prevention of smoking, and so forth. And I think they're realizing that it costs less in the long run to prevent disease than to treat it after it's happened. And I think that's one of the positive things of HMOs, and it's in sponsoring a number of these various types of clinics and so forth. And all it extends to proper nutrition, proper prenatal care, and so forth. And I think that's one of the positive things that they're trying to do. Negative things, well, we mentioned before, they can try to control too much by the dollar what the patient's going to receive rather than the medical necessity of it.
Were you ever directly affected by the emergence of Medicare, Medicaid, and HMOs, generally managed care?
Well, economically, I can remember before the days of Medicare, that a great number of the elderly people we took care of, there was no reimbursement. So when Medicare came in, their incomes went up because this whole huge group of patients was now covered by insurance that paid for physicians' care and hospital care. So to me, when Medicare care first came in, it was an increase in people's income. Now, Medicaid is a different story. That's not paying probably what it should, and a lot of physicians, as a result, are refusing to take care of Medicaid patients, and that's the bad or the downside on Medicaid. And I was never much involved with that. We had some Medicaid patients, and our group always accepted whatever Medicaid paid, and we, just was one of the things. Anesthesia, we never knew ahead of time whether patients were covered with insurance or not. So from our standpoint, it was after the fact that we found out whether we get paid or not. Or a lot of, excuse me, a lot of elective type surgery, physicians would decide whether they were going to do it or not, depending on whether the patient had insurance. But I don't think it involved anesthesia that much because, as I say, we never knew beforehand whether the patient could or would pay or not. We just gave our services as required. Excuse me.
How have doctors' salaries changed over the course of your practice?
Skyrocketed. The incomes have skyrocketed. And to me, I know I get in the doghouse when I mention this to a lot of other physicians, but I think physicians are overpaid today. In particular, certain type specialties, extremely overpaid. I think pediatricians and general practitioners are underpaid. I can think that some specialties where I think they're grossly overpaid. For a 10-minute operation, $1,000, $2,000 reimbursement for it is, to me, it's I can't conceive of that. But I'm in the minority, and I guess thinking that way.
So you were in a group practice, right?
Yes, always in a group practice.
All your income came from your monthly salary or your...
Well, we just split it up, and depending on what we took in, and had a percentage distribution on it.
How has malpractice insurance changed over the years, as well as its impact on doctors' practices?
Well, that's one of the things that's malpractice insurance has changed dramatically. When I first started out, I think the first few years I was in practice, my malpractice insurance premium was like maybe $180 a year, and those days there was an outfit called Medical Protective of Fort Wayne, Indiana, that most doctors were insured by. I mentioned, I think $180 a year. Well, today, in many specialties, you pay that per day for malpractice. I remember in latter years, when I was still in practice, we were paying, I can't think of the exact figures, but it seemed to me anesthesiologists were getting up to maybe the $40,000 a year malpractice premium. And you had to work a good many months just to be able to pay your premium. And I know obstetricians, orthopedic surgeons, neurosurgeons are paying much higher than we are, and their costs are just prohibitively high, all caused by the everyone wanting to sue, and it's changed medicine for the worse. I think that's one of the big drawbacks of medicine today, the thought of malpractice. Awards being given, and some of the awards are just outrageous. I think a person's, due to some type of malpractice, should be compensated, but not to the extremes that juries are giving multi-million-dollar awards. And that's just been one of the real drawbacks of medicine today.
Well, on a different note now, how much did it cost for you to go to medical school, Dr. Harges?
Well, it's hard to realize today. I think medical school cost me $60 because I mentioned I was sent to medical school while I was still in uniform. For my first half year in medical school, I was in the Navy, so that was all paid for. Then I had the GI Bill, having been in the Navy for a number of years. And so the GI Bill took me, I was entitled to basically all my medical school cost up till the last semester of my senior year. And I remember I had a lab fee. I went to a state university, which the tuition was practically nothing. But I had I think a $60 lab fee for my last semester of medical school. I remember asking my dad for $60 to pay the lab fee, because that's not the whole story either. I worked all throughout medical school. I had jobs on the side, and so it was but out of pocket, I think it cost me $60. A far cry from today, when kids getting out of medical school are indebted. Even out of college are indebted thousands of dollars, sometimes $100,000 in medical school. I hear people owing total bills of $150,000, $180,000 by the time they graduate from medical school. It's just incomprehensible to me when I think back at $60.
Do you think the debts that they come out with influences their choices of how to practice medicine at first?
Well, I think so. Some of them have gone in. The National Health Service has, I guess they still have the program, or if you go to underserved portions of the country and serve for a couple of years, they will absorb a good part of your debt and so forth. And so it does influence sometimes where people practice for the first 3 or 4 years. And also, when they end up with debts like that, they want to get into the high-paying specialties to try to pay their debts off. So they seek to go into ophthalmology or radiology or anesthesia today, which is a high-paying specialty, to try to pay off their debts as fast as possible. So sometimes I think they pick their specialties for the income rather than their great desire or great interest in that particular specialty. Again, I probably in the minority in the way I think on that.
Did you see any doctors back when you went to medical school around that time? Did you see any doctors then who were ever influenced that way by finances in medical school?
Well, I can't think of any really.
Of course you weren't, right? Because you only paid $60.
Yeah. Well, I remember a lot of my classmates, it seemed to me that in medical school in those days, people didn't get into debt. I went to a state university, and a lot of my classmates, we had jobs on the side. People would work in the school cafeteria for their food, for their board, and I had a job as secretary or treasurer of the fraternity for a couple of years, so I got my room and board for nothing on that. I worked in the hospitals in the evening and covering emergency wards and so forth, which you couldn't do today as a medical student those days in Chicago. Why medical students would sometimes work in various hospitals doing histories and physicals. I worked in the city prison of Chicago for 2 years going through medical school as, quote, the doc, the prison doc, and a lot of interesting stories to tell about my days as the, as, quote, the doc out at the city jail in Chicago. So all these jobs kept my expenses, I say, to $60 when I ran out of money finally.
What are some changes that you've seen in the demographics of Worcester?
Well, it's changed considerably. In recent years, you have a large influx of Latin America immigrants, and there seems to be a large Asian influx. The boat people, Vietnam, seem to be coming in, and one time Worcester, other than a small black community, was all white. And today, I think you see in the Worcester area maybe 20% non-native people. So it is changing dramatically in recent years in Worcester, Worcester County, other towns, Pittsburgh, Clinton, Leominster. Take all the towns around, they're getting a large influx of non-native people.
How has women's health in Worcester changed over the course of your practice? Have you observed anything?
Changes in women's health? I can't think of anything offhand. I think there's more and more emphasis on the proper prenatal care for women. In recent years, of course, the scare of breast cancer has brought into the use of mammography to a great extent, which is a recent, relatively recent innovation in women's care. So I think the prenatal care and the fear of breast cancer has changed the treatment of women a lot. And in recent years, too, the osteoporosis seems to have women concerned about that and the treatment of osteoporosis. And so there have been changes in women's care.
Have there been changes in how children are cared for at all?
Oh, I think there have been changes. At one time, in Memorial Hospital, there was a children's ward, and I can think of during the winter season with colds and coughs, 30, 40 children at a time would be inpatients. Today, that would be verboten, I would say. You can't hospitalize children with the sniffles and a little cough and fever like they did years ago. And as a result, over the years, the hospital after hospital did away with their children's wards because they're really one they need for the hospitalization that we used to see years ago. So that's all been a change for the good. Because, you know, if you get one kid with a contagious disease and bring other kids in with just the sniffles, then pretty soon you're spreading disease rather than curing it. And I don't know how they ever got away with it years ago with admitting so many children to hospitals. And there's been a big, big change for the good in that.
How do you feel the role of the physician in the Worcester community has changed?
I'm trying to think if there have been many changes in the way physicians practice or not. I think one thing, there's more group practice, and particularly in specialties like obstetricians. At one time, all the obstetricians were basically solo practitioners, and pediatricians mainly solo, and as the years have gone by, I've seen more and more. I think the younger group won't go into some of these specialties unless they're in a group practice. So I think obstetricians basically are in group practices, and pediatricians, and most of them are seen to be in group practices. So I think the change has been more to group practice in certain specialties. So to give them better hours, more time off, and not being run into the ground and being perpetually tired because they're on call 24 hours a day. So that's been to the good.
Yeah, we have 2 minutes left. Why did you choose to practice here in Worcester?
Well, it was a desire to get out of Boston. I mentioned earlier I hated when I lived in Natick, I was commuting to Boston every day. I just hated the Boston traffic and everything, and I just I didn't want to stay in the group I was with. It was a dead-end job. They were just I was out training and they were paying peanuts, and I was looking around and found an opening in Worcester, and I thought, well, I had this opportunity to come to Worcester without having to move, and so I thought, well, it won't cost anything to move. I'll just give it a trial and see how it works out. And it worked out, and it was just the breaks of the game that brought me to Worcester. I liked Worcester area. It was, a lot of people years ago, it's still called, I guess, Wormtown among the college students and everything, but I always found it a very pleasant place to live, and physically around the Worcester area is a beautiful spot of New England, and I liked it and just have stayed.
Is there a favorite memory from your career that you would briefly like to share?
I can't think of any one particular favorable experience I had. There have been a lot of them, a lot of good ones, a lot of bad ones, but I just can't elicit them at this point as being, completely outstanding at all.
Okay. And lastly, what advice do you have for younger doctors?
Well, my advice to younger doctors was practice medicine as you see fit medically, and not worry about the threat of malpractice or what the government tells you to do and so forth. And I know that's hard to accept, but and go into it with the expectation not of the financial rewards, but go into it because you enjoy doing it, and I think life would be a lot happier for people if it